Morning class. So today we're going to be going over chapter 26, soft tissue injuries. So trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Soft tissue trauma, recognition and management of wounds, burns. Different kinds of burns are going to be electrical, chemical, and thermal. Chemicals in the eye and on the skin. Pathophysiology, assessment and management, wounds, avulsions, bite wounds, lacerations, puncture wounds, incisions. And then burns again, electrical, chemical, thermal, radiation, and crush syndrome. Soft tissue injuries are common, simple as a cut or a scrape, serious as a life-threatening internal injury. Do not become distracted by dramatic open wounds. Do not neglect airway obstruction. So some wounds we call are distracting injuries, maybe an open compound fracture, and we focus in on that. We can't get tunnel vision. We want to make sure that we're doing the full assessment and make sure we're not missing anything. So soft tissues of the body can be injured through a variety of mechanisms: blunt injury, penetrating injury, barotrauma, and burns. Soft tissue trauma is a common form of injury. Death is often related to hemorrhage or infection, such as sepsis. Soft tissue injuries can often be prevented by simple protective actions. The anatomy and physiology of the skin. The skin is the body's first line of defense against external forces, infection. It's a good thing to remember that. That's probably going to be a test question. The skin is relatively tough but still susceptible to injury. It range from simple bruises and abrasions to serious lacerations and amputations. In all instances, the EMT must control bleeding, prevent further contamination to decrease the risk of infection, protect wounds from further damage, apply dressings and bandages to various parts of the patient's body. Skin varies in thickness, thinner in the very young and very old, thinner on the eyelids, lips, and ears, then on the scalp, back, soles of feet. Thin skin is more easily damaged than thick skin. So this is why in minor injuries in the very young and very old, we have a high index of suspicion for, because they're more prone to get injured, especially in the skin. Older people tend to have more skin tears and tend to bleed a lot more, especially depending on the medications they're on, such as blood thinners, warfarin, Coumadin, Eliquis. The skin has two principal layers, the epidermis and the dermis. Epidermis, tough external layer. Dermis is inner layer. So you want to know the different layers of skin, especially when we're talking about burns. So right here we have the anatomy of the skin. So yeah, the very first layer is epidermis, the dermis, and then down at the bottom this is going to be the subcutaneous tissue or the fatty tissue. So skin covers all the external surfaces of the body. Bodily openings are lined with mucous membranes, provide a barrier against bacterial invasion, secrete a watery substance that lubricates the openings. Skin serves many functions, keeps pathogens out, keeps fluids in, helps body regulate temperature. Nerves in the skin report to the brain on the environment and sensations. This is especially helps body regulate temperature. This is why a lot of people die from burns, is because their skin has been burned off, all their sensors are gone, and they can't regulate body temperature anymore. So it's important to know that, important to get people to burn centers when needed. So any break in the skin may allow bacteria to enter and increase the possibilities of infection, fluid loss, a loss of temperature control. 3 types of soft tissue injuries: closed injuries, damages beneath skin or mucous membrane, surface is intact. Open injuries, break in surface of skin or mucous membrane, exposes deeper tissues to contamination. 3 types of soft tissue injuries: burns, damage results from thermal heat, frictional heat, toxic chemicals, electricity, or nuclear radiation. So pathophysiology of closed and open injuries. Pathophysiology: cessation of bleeding is the primary concern, basically stopping of the bleeding. The next wound healing stage is inflammation. A new layer of cells is then moved into the damaged area. New blood vessels form. Collagen provides stability to the damaged tissue and joins wound borders. Closed injuries. Characteristics of closed injuries: history of blunt trauma, pain at the site of injury, swelling beneath the skin, discoloration. So contusion or a bruise causes bleeding beneath the skin but does not break the skin. I'm sure you guys have seen this, have this had happen to you before. When you guys get hit with something or bump into something, you guys could get a contusion. Discoloration of the skin. It's caused by blunt forces. Buildup of blood produces blue or black ecchymosis. Hematoma is blood collected within damaged tissue or in a body cavity. So a crushing injury occurs when a significant amount of force is applied to the body. Extent of damage depends on amount of force. Length of time force is applied. When an area of the body is trapped for longer than 4 hours, crush syndrome can develop. We talked about this last week. What is crush syndrome? So compartment syndrome results from the swelling that occurs whenever tissues are injured. Severe closed injuries can also damage internal organs. Assess all patients with closed injuries for more serious hidden injuries. So open injuries. In an open injury, the protective layer of the skin is damaged. The wound is contaminated and may become infected. 4 types: abrasions, lacerations, avulsions, penetrating wounds. Abrasion is more, if you guys have ever played on the grass and you kind of skin your knee on the grass, it's not really cuts or lacerations. It's more kind of an abrasion. Avulsions are kind of like skin flap tears, where you still have a piece of skin covering over the laceration. And then I'm sure you guys know what a laceration and penetrating wounds are. So an abrasion is a wound of the superficial layer of the skin caused by friction when a body part rubs or scrapes across a rough or hard surface. So this is going to be an abrasion right here. Most likely you guys have been out on the grass and skinned your knee. It's where you're mostly going to get it for the most part, an abrasion. And then a picture. So a laceration is a jagged cut caused by a sharp object or blunt force that tears the tissue. An incision is a sharp, smooth cut. And then you have a couple lacerations and incisions right there. Okay. An avulsion separates various layers of soft tissue so that they become either completely detached or hang as a flap. Often there is significant bleeding. It's kind of hard to tell the avulsion right here, but you can still see we have a laceration right here, and we still have some of the skin attached, and it's going to just fall back over the wound. That's what's called an avulsion. So an amputation is an injury in which part of the body is completely severed. A penetrating wound is an injury resulting from a piercing object. Can damage structures deep within the body. Stabbings and shootings often result in multiple penetrating injuries. Assess the patient carefully to identify all wounds. Count the number of penetrating wounds. Determine the type of gun when possible, but do not let delay transport. You may have to testify in court. This is what I've talked to you guys about to make sure you got your guys' PCRs are detailed, especially in cases of GSWs or stabbings or assaults even. You may be called to go to court and testify. Lawyers are going to look at your PCR. They're going to try and poke holes in every little thing that's on your PCR. This is why we go over our PCRs before we send them in. We want to make sure there's no errors. Make sure there's no contraindications. Anything that they could be used against you, the lawyers are going to use against you. So make sure your PCRs are detailed and thorough, and they all match up. So blast injuries. Primary blast injury, damage caused by the blast wave and sudden pressure changes. Secondary blast injury, damage results from flying debris. Tertiary blast injury, victim is thrown by explosion, perhaps into an object. So we saw this last lecture, the different types of blast injuries. You guys should know all the differences. Most likely you're going to get a question on what is a primary blast injury, what's a tertiary blast injury. So patient assessment of closed and open injuries. More difficult to assess a closed injury than an open injury. You can see an open injury. Consider the possibility of a closed injury when you observe bruising, swelling, deformity, the patient reporting pain. So scene size up. First thing we're going to do on every call, scene safety. Observe the scene for hazards to your crew, bystanders, and the patient. Consider the need for additional resources. Take the necessary standard precautions. Be careful where you put your hands. Place your equipment and how you package your patient. Focus on controlling the bleeding. Mechanism injury. Look for indicators of MOI as you assess the scene. The MOI may provide information about potential safety threats. Evaluate scene safety and consider additional resources. Always call for more resources than you think you need. You could always cancel them. The longer you wait, the longer you're going to delay patient care if there's more resources that you need or more patients than you can handle. So always call more resources than you need. You could always cancel them. Primary assessment. Identify life threats and transport priority. Form a general impression. Look for indicators of the patient's condition. Check for more serious hidden injuries. Check for responsiveness. So every time you're walking up to a patient, you're forming a general impression. You want to make sure. Use the ABPU scale. Alert, verbal, painful, unresponsive. Is the patient tracking you when you get in? How's the patient positioned? Is the patient prone on the ground? Is the patient supine? Is the patient lying on the side? And look around the patient. Look for any clues to give you any ideas of what's going on with the patient. Sometimes you're going to get calls for unknown medical. Sometimes they're going to be traumas instead of medicals. So always be on the lookout, looking for clues. So airway and breathing. Provide high flow oxygen. Ensure that the patient has a clear and patent airway. Protect the patient from further spinal injury. Assess the patient for adequate breathing. Inspect and palpate the chest for decap BTLS. So circulation. Assess the patient's pulse rate and quality. Determine the skin condition, color, and temperature. Check the capillary refill time. You may need to treat the patient for shock. Transport decision. Immediate transport in these cases. Poor initial general impression. Altered level of consciousness. Dyspnea. Abnormal vital signs. Shock. Severe pain. Investigate the chief complaint. Obtain a medical history. Obtain a sample history on every patient if you can. Using OPQRST may provide some background on isolated extremity injuries. Try to use sample OPQRST and decap BTLS together if possible. If the patient is unresponsive, attempt to obtain the history from other resources. So ask bystanders, ask family members, ask friends if they're around, what their sample history is. So typical signs of an open injury: bleeding, breaks in the skin, shock, hemorrhage, disfigurement or loss of a body part. Secondary assessment. After you evaluate ABCs and treat immediate life threats, a more detailed assessment should follow. Secondary assessment is a more systemic full body scan. Typically occurs en route to the emergency department. Physical examination. Listen to breath sounds on every call. Determine the respiratory rate. Note the pattern and quality of the respiratory effort. Is the patient labored? Is the patient shallow? Is the patient rapid breathing? Assess for asymmetric chest wall movement. Physical examination. Assess the neurologic system. Assess the musculoskeletal system with a detailed exam of entire body. Assess all anatomic regions. Vital signs. Reassess the vital signs to identify how quickly the patient's condition is changing. Signs that indicate hypoperfusion and the need for rapid transport: tachycardia, tachypnea, and low blood pressure. And weak pulse, cool, moist, and pale skin. This normally means patients probably losing blood somewhere. All the blood shunting to their vital organs. So you're going to have cool, moist, and pale skin on the peripherals or the extremities. Reassessment indicates how well the patient is tolerating the injury and the effectiveness of your interventions. Reassessment. Repeat the primary assessment. Assess the effectiveness of prior treatments. Reassess vital signs and the chief complaint. Recheck patient interventions. Reassess bandaging. Identify and treat changes in the patient's condition. Interventions. Assess and manage all threats to the patient's airway, breathing, and circulation. Give oxygen to patients with traumatic injuries that impact the airway or ventilation or those with the potential for shock. Never withhold oxygen. Do you think a patient needs oxygen? Go ahead and give it to them. Expose all wounds, control bleeding, and be prepared to treat for shock. So when you have a trauma patient, you're cutting everything off. Cut all his clothes. You're going to strip and flip. Make sure you don't miss anything. Make sure you don't miss any bleeding, any cuts, wounds, anything that you can control before you put them on the board. Okay. Flush small wound surfaces with sterile saline prior to applying a dressing. Do not remove any material stuck in the wound. Splint extremities that are painful, swollen, or deformed. So for our protocol, and I'm not sure what it says in your guys' book, but if you have a pulseless extremity, you're going to try and realign it if possible. Just one time. If it's too painful or you can't realign it, you're going to transport immediately, code 3 to the hospital if it's still pulseless. If you still got a good pulse in their extremity and you try and realign it and you can't do it, you're just going to go ahead and put it in a comfortable position. Just leave it in place and go to the hospital. Do not keep trying to straighten out an extremity that's broken if the patient can't tolerate it. So communication and documentation, description of the MOI, position in which you found the patient, amount of blood loss. Just estimate how much blood loss you think the patient lost. You don't have to be exactly precise. Go outside, fill up a water bottle, fill up a 12-ounce water bottle, or go fill up a half a gallon water jug, throw it on the ground, see what it looks like. And that way you kind of guesstimate. Oh, patients lost half a liter. Patients lost a liter. Patients lost 200 cc's of blood. I usually try and go in and tell the doc how much blood I think the patient's lost. It doesn't have to be precise, but somewhere in the general vicinity of amount of blood loss you think the patient lost. So location and description of any soft tissue injuries or other wounds. Size and depth of the injury. How you treated the injuries. So every time I see an injury on my patient and I write in my PCR, I always use approximate before everything. Patient has an approximate 1-inch laceration on his arm, approximately ½ inch deep, ½ inch wide. And then how you might have treated those injuries. I put a sterile bandage over and I wrapped it up, or I put an ice pack on it, or I splinted it. Anything along those lines, if you have time. Emergency medical care for closed injuries. No special emergency care for small contusions. Extensive injuries could lead to hypovolemic shock. Closely watch any area of injury, no matter how minor. Treat closed soft tissue injury using the Rice mnemonic. Rest, ice, compression, elevating, and splinting. So for any of you guys who have sprained an ankle, or who play sports, they're going to tell you to use the Rice method. Rest it, ice it, compress it, and elevate it, and splint it if possible. So go home, lay in bed, or sit on the couch, put a couple pillows underneath your ankle, and throw some ice on it. So signs of developing shock, anxiety or agitation, changes in mental status, increased heart rate, increased respiratory rate, diaphoresis, cool or clammy skin, decreased blood pressure. Emergency medical care for open injuries. Before caring for the patient, follow standard precautions. You're putting on gloves on every single patient, every single call. If life-threatening bleeding is observed, assign a team member to apply direct pressure. Cover wounds of the chest, upper abdomen, or upper back with an occlusive dressing. Control bleeding using direct, even pressure and elevation. Pressure dressing or splints or tourniquets if the patient's bleeding is severe. If you have an arterial bleed, most likely you go straight to a tourniquet. You're going to put direct pressure on it first, but then tourniquet. All open wounds are assumed to be contaminated and present a risk of infection. This is why we use PPE on every single call. Control bleeding by splinting the extremity, even if there is no fracture. So abdominal wounds. An open wound in the abdominal cavity may expose internal organs. And in evisceration, organs protrude through the wound. So these are Eviscerations. Do you guys remember how to treat? So you're gonna throw some sterile water on a trauma dressing and just lay it over. You're not gonna try and push the organs back in. So cover the wound with sterile gauze. Secure the gauze with an occlusive dressing. Keep the organs moist and warm. Okay, so just throw it right over. Make sure it's not getting infected if possible. Try and cover the whole organ area. So impaled objects. Remove an impaled object only when the object is in the cheek or mouth and obstructs the airway. The object is in the chest and interferes with CPR. So these are the only 2 times you're going to move an impaled object. Everywhere else you're going to leave it in. So neck injuries. Open neck injuries can be life-threatening. Open veins may suck in air and cause cardiac arrest. Cover the wound with an occlusive dressing. Apply manual pressure, but do not compress both carotid arteries at the same time. So, especially neck injuries are tough to deal with because you want to control the bleeding, but you also don't want to close the patient's airway. So some people actually put a sterile dressing on their neck and then place a C-collar around it. And that's a good way to hold it in, holding the bleeding if possible. So small animal bites. A small animal's mouth is heavily contaminated with virulent bacteria. Wounds may require debridement, antibiotics, tetanus, prophylactics, surgical repair. Bites should be evaluated by a physician. So debridement. This is why we try and keep all injuries as sterile as possible and as clean as possible. Because they're going to have to go out and clean all the stuff out of there before they wrap it up. And that hurts a lot. They also going to ask you, when's the last time you had a tetanus shot? Because they might give you another tetanus shot. Okay? And then some severe bites are going to require surgery. So a major concern is the spread of rabies. Acute, potentially fatal viral infection of the central nervous system can affect all warm-blooded animals. Transmitted through biting or licking an open wound. Prevented only by a series of special vaccine injections. Human bites. The human mouth contains an exceptionally wide range of bacteria and viruses. Regard any human bite that has penetrated the skin as a very serious injury. Can result in a serious spreading infection. So this is another exposure. If you ever get bitten by someone, and it happens, you're going to have to fill out an exposure report. You're going to have to get tested. Your patient's going to have to get tested. And you might have to get on some antibiotics, depending on what the patient has. So emergency treatment. Apply a dry, sterile dressing. Promptly immobilize the area with a splint or bandage. Provide transport to the ED. So burns account for approximately 3,400 deaths per year, among the most serious and painful of all injuries. A burn occurs when the body receives more radiant energy than it can absorb. Sources of the energy may include heat, toxic chemicals, and electricity. Always perform a complete assessment to determine whether other serious injuries are present. Children, older patients, and patients with chronic illnesses are more likely to experience shock from burn injuries. Pathophysiology of burns. Burns are soft tissue injuries that are created by the transfer of radiation, thermal, or electrical energy. Thermal burns occur when the skin is exposed to temperatures higher than 111 Fahrenheit. Severity of a thermal injury correlates directly with temperature, concentration, amount of heat energy possessed by the object or substance, duration of exposure. The greater the heat injury, the deeper the wound. People reflexively limit heat energy and exposure time. They cannot do so if unconscious or trapped. When a person is burned, the skin that acts as a barrier is destroyed. Burns create a high risk for infection, hypothermia, hypovolemia, and shock. So remember, skin regulates body temperature. So anytime you have parts of the body that are burned, the skin can no longer regulate body temperature in that area. That's why they suffer from hypothermia. Burns to the airway are of significant importance. Circumferential burns of the chest can compromise breathing. Circumferential burns of an extremity can lead to neurovascular compromise and irreversible damage. So these are moderate to extreme burns depending on how circumferential they are. You're probably going to go straight to a burn center if you have any of these types of burns, especially burn to the airway. So burn severity. Burn severity depends on the depth of the burn, the extent of the burn, and the critical areas involved. So any critical areas would be the face, upper airway, hands, feet, and genitalia. Pre-existing conditions or other injuries, patients younger than 5 or older than 55. So depth of burns. Superficial, first-degree burns involve only the top layer of the skin. Partial thickness or second-degree burns involve the epidermis and some portion of the dermis. Blisters are present. Full thickness, third-degree burns extend through all skin layers. So if a patient has no feeling in a burn, that's going to be a third-degree burn or full thickness. So remember the different types of burns, first-degree, second-degree, and third-degree, and what else they're called. So third-degree is also full thickness. Second-degree is partial thickness, and superficial is just a first-degree burn. So a superficial burn, it's going to be like a sunburn. Okay. So here you go. We got a sunburn right here. It's a first-degree burn. Okay. This is going to be your second-degree burn. This is, you kind of see blisters develop over here. Okay. This has gone through the epidermis. Okay. It's down to the second layer of skin. Okay. So this is a full thickness third-degree burn. Okay. Kind of see black marks here and there. It's gone through the whole skin. So extent of burns, estimating using the rule of Palm or rule of nines. The proportions differ for infants, children, and adults. Include only partial thickness and full thickness in estimations of the extent of burn injury. So make sure you know your rule of palms. So look at the patient's palm. How big is their palm? That's a rule of 1 or a rule of palm. So that's 1% of their body. Okay. So here you go, rule of nines for an adult. So the front of his arms are going to be 9. The back of his arms are going to be 9. So the top half of his chest, because this is the top half of his torso, is going to be 18. So you split it up. The top half is going to be 9. Bottom half is going to be 9. Okay, so for 18. The head's going to be 9. The back, the same thing. The top of the back, it's going to be 9. Bottom of the back is going to be 9. And same thing. So 18 at the front, you split it in half and it's 9. And the back is also 18. Okay. So, and it's going to be a little different for kids and infants as well. So make sure you guys know your rule of nines. You guys might get tested on that. And your rule of palm. Okay, patient assessment of burns. When you're assessing a burn, it is important to classify the victim's burns. Classification of burns is based on the source of the burn, the depth of the burn, and the severity of the burn. Okay, so make sure, try and figure out what the patient got burned on. Was there hot oil? Was it a patient making hot tea and it fell? The depth of the burn, what kind of burn was it? How deep did it go? Was it second degree? Was it third degree? Or was it first? And then severity of the burn. So the surface area. 5% of a second degree burn on the patient's hand from using hot tea. So, scene size it. Scene safety. Observe the scenes for hazards and safety threats. Ensure that the factors that led to the patient's burn injury do not pose a hazard. Mechanism of injury. Determine the type of burn that has been sustained and the MOI. So gather information from the patient about the extent of the injury. Assess the scene for environmental hazards. You want to make sure you're not walking into something that's going to affect you or get you injured. Especially if you're going into like chemical plants or electricity plants. Determine the number of patients. Make sure you know how many patients there are. And then call for additional resources if needed. Call for it early. Consider the potential for other injuries. So primary assessment, begin with a rapid exam, form a general impression. Look for clues to determine the severity of injuries and the need for rapid treatment. Be suspicious of clues that may indicate abuse. Consider the need for manual spinal stabilization. Check for responsiveness using the ABPU scale. Airway and breathing. Ensure that the patient has a clear and patent airway. Be alert to signs that the patient has inhaled hot gases or vapors. Singed facial hair. Soot present in and around the airway. So this is also part of your general impression when you're walking up, and even when you're talking to the patient. Look at how they're presenting. Look at their face. If they're complaining of difficulty breathing, make sure that the hot gases or vapors didn't get in their airway. So heavy amounts of secretions and frequent coughing may indicate a respiratory burn. So always listen for lung sounds. Remember, every call you're listening for lung sounds. Quickly assess for adequate breathing. Inspect and palpate the chest wall for decap BTLS. Circulation. Assess the pulse rate and quality. Determine perfusion based on the patient's skin condition, color, temperature, and capillary refill time. Control significant bleeding. Assess for shock. Transport decision. Consider rapid transport for a patient who has an airway or breathing problem, significant burn injuries, significant external bleeding, signs and symptoms of internal bleeding. Consider consulting ALS providers. So history taking. Investigate the chief complaint. Be alert for signs and symptoms of other injuries due to the MOI. Typical signs of a burn: pain, redness, swelling, blisters, charring. So blisters are most likely to be associated with what kind of burn? A second degree or partial thickness. Charring of the skin is probably going to be associated with what? A third degree or full thickness burn. So regardless of the type of burn injury, stop the burning process. Apply a dressing to prevent contamination. Treat the patient for shock. So we have special sheets for anybody who's been burned. You're not going to just put 4x4 gauze on the patient. You're going to put a burn sheet. You put gauze on a patient, it's going to stick to the patient. They're going to have to clean that out. They're going to have to debride the injury. And that's going to hurt, especially for a serious burn. Sample history. Along with the sample history, ask the following questions. Are you having any difficulty breathing? Are you having any difficulty swallowing? Are you having any pain? Check whether the patient has an emergency medical identification device. So you could check, most likely they're going to have it on their wrist. It's going to tell you, that's going to be a medical bracelet. It's probably going to tell you allergies or DNR. Sometimes older patients have a life alert. It's going to be a necklace that goes around their neck. So physical examination. Perform an exam of the entire body. Assess the patient from head to toe looking for decap BTLS. Make a rough estimate using the rule of nines of the extent of the burn area. Determine the classification of the burn. Determine the severity of the burn. Package the patient for transport. So assessment of the respiratory system involves looking, listening, and feeling. Assess the patient's neurologic system. Assess the musculoskeletal system. Determining an early set of vital signs will help you to know how the patient is tolerating his or her injuries. Reassessment. Remember, reassess every patient. Reassess an unstable patient at 5 minutes. Reassess a stable patient at 15 minutes. Repeat the primary assessment. Reassess the patient's vital signs. Reassess the chief complaint. Is the complaint getting better? Is it getting worse? Has it changed? Reevaluate interventions. Stop the burning process. Assess and treat breathing. Support circulation. Provide rapid transport. Oxygen is mandatory for inhalation burns and large body surface area burns. So go ahead and throw oxygen on the patient, especially if a patient's coming out of a burning building or something, or any type of possibly inhaled burns. Just throw oxygen. Go ahead and throw a non-rebreather on them. 15 liters. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. So communication and documentation. Provide hospital personnel with a description of how the burn occurred. Describe the extent of the burns, amount of body surface involved, depth of the burn, location of the burn. So this is a good 3 things you want to give to the hospital and you want to tell the doctor. so they know what they're going to be prepared for. Okay, document if special areas are involved. So any head, airway, genitalia, any extremities, any circumferential burns. So emergency medical care for burns. Stop the burning process. It's the first thing you're going to do on every burn, and then prevent additional injury. This is what you're going to do on every call. You're going to prevent any additional injury if you can. So thermal burns caused by heat. Most commonly, they are caused by scalds or an open flame. A flame burn is very often a deep burn. Hot liquids produce scald injuries. So we do get this a lot. Parents will be making hot tea or boiling water, and they'll walk away, and their young kids will go up and accidentally grab the pot of water, and it'll fall on the patient. This is how we get hot liquids and scald injuries. Coming in contact with hot objects produces a contact burn. A steam burn can produce a topical scald burn. A flash burn is produced by an explosion. May briefly expose a person to very intense heat. Lightning strikes can cause a flash burn. Management. Stop the burning source. Cool the burn area and remove all jewelry. This is especially important because your hands are probably going to swell up if they're near the burn, and it's going to be hard to get jewelry off. So you're going to have to, the hospital's probably going to have to cut the jewelry off, especially if it's expensive. The patient's probably not going to be happy about that. So you want to remove all jewelry first if you can. Increased exposure time will increase damage to the patient. All patients should have a dry dressing applied to maintain body temperature, prevent infection, and provide comfort. Inhalation burn can occur when burning takes place in enclosed spaces without ventilation. Upper airway damage is often associated with inhalation of superheated gases. Lower airway damage is often associated with inhalation of chemicals and particulate matter. You may encounter severe upper airway swelling, which requires immediate intervention. Consider requesting ALS backup. The combustion process provides a variety of toxic gases. Carbon monoxide intoxication should be considered whenever a group of people in the same place all report a headache or nausea. Management. First, ensure your own safety and the safety of your coworkers. So, for carbon monoxide, do not rely on your SpO2 monitor or your pulse oximetry monitor. If it says patient's getting 100% and you think they've been exposed to carbon monoxide, give them oxygen. That is mandatory to give them oxygen. The pulse oximetry just reads how much your hemoglobin is saturated with. It doesn't tell you what it's saturated with. Carbon monoxide binds to hemoglobin about 250 times more than oxygen. So a patient could be filled with carbon monoxide and you wouldn't know it. Give them oxygen every single time, or your patient could die. Management. Pre-hospital treatment of a patient with suspected hydrogen cyanide poisoning includes decontamination and supportive care. Care for any toxic gas exposures includes recognition, identification, supportive treatment. Chemical burn can occur whenever a toxic substance contacts the body, generally caused by strong acids or strong alkalis. The eyes are particularly vulnerable. Do we give activated charcoal for acids, inhaled or ingested acids or alkalis? No, we don't. So severity of the burn is directly related to three factors: type of chemical, concentration of the chemical, duration of exposure. Wear appropriate chemical resistant gloves and eye protection. So management, remove any chemical from the patient. Always brush dry chemicals off the skin and clothing before flushing with water. Remove the patient's clothing. So here, it's kind of hard to tell, but you got a bunch of white stuff all right here. So you're just brushing all the stuff off. And then you're going to wash them down. Try and get as much as possible off before you start flushing with water. Because that water is going to make all that stuff go leak down to the further parts of the body and could cause further damage. So that's why we always want to dry brush the chemicals off if we can. So for liquid chemicals, immediately you begin to flush the burn area with lots of water. Continue flooding the area for 15 to 20 minutes after the patient says the burning pain has stopped. If the patient's eye has been burned, hold the eyelid open while flooding the eye. Conduct proper decontamination prior to loading the patient. Remember what I talked to you guys about? We got to flush the eye out for at least 10, 15, possibly even 20 minutes. Are you going to open the eye and hold water over the patient for a solid 10 or 15 minutes? Probably not. So grab an IV bag, grab a nasal cannula, hook it up, and turn the nasal cannula over and just let it run. You could always put another IV bag up. So electrical burns may be the result of contact with high or low voltage electricity. For electricity to flow, there must be a complete circuit between the source and the ground. Insulator, any substance that prevents a circuit. Conductor, any substance that allows a current to flow. The human body is a good conductor. The type of electric current, magnitude of current, and voltage have effects on the seriousness of the burn. Your safety is of particular importance. Never attempt to remove someone from an electrical source unless you're specially trained to do so. So let the professional handle it. If it's a hazardous material problem, let the hazardous material technicians or specialists solve the problem before you get in there. A burn injury appears where the electricity enters and exits the body. So 2 dangers. There may be a large amount of deep tissue injury. The patient may go into cardiac or respiratory arrest from electric shock. So basically it's going to defib a patient that's living. It's going to cause so much electricity to the heart that it could stop it. It could throw it into a lethal rhythm. So especially if you get like a lightning strike or something, always be prepared to bring your AED. I mean, you're going to bring your AED on every call, but you might have to throw that on as soon as possible. So be aware of lightning injuries or electricity burns. The patient may be in cardiac arrest when you get there. So picture of an electric burn. So management, if indicated, begin CPR on the patient, apply an AED. Be prepared to defibrillate if necessary. Give supplemental oxygen, monitor the patient closely. Treat soft injuries with dry, sterile dressings. Provide prompt transport. So remember, like I said, make sure you have your AED ready to go. If you already know the call, they already tell you what the patient's been struck by lightning, patient's down an electric burn. Make sure you have that AED. Make sure you're ready to go and put those pads on. Patient might be in cardiac arrest. So taser injuries. In recent years, law enforcement has increased its use of tasers. Potential complications for patients with underlying disorders. Use of a taser has been associated with dysrhythmias and sudden cardiac arrest. Make sure you have access to an AED when responding to patients who have been exposed to taser shots. So this is the same thing as an electricity burn or a lightning burn, because a taser is just full of electricity, and it could shock the patient into a lethal dysrhythmia and possibly lead to sudden cardiac arrest. So make sure you have your AED ready. So radiation burns. Potential threats include incidents related to the use and transportation of radioactive isotopes, intentionally released radioactivity in terrorist attacks. You must determine if there has been a radiation exposure and then whether ongoing exposure continues to exist. 3 types of ionizing radiation. Alpha, little penetrating injury, easily stopped by the skin or even clothing. Beta, greater penetrating power but blocked by simple protective clothing. Gamma, very penetrating, easily passes through the body and solid materials. So an example of gamma is probably going to be a CT scanner. When you guys go in there, they usually have you wearing a vest or something like that because of all the radiation going on. And that's why all the people in the room stand behind the wall or even wear protective gear. So most ionizing radiation accidents involve gamma radiation or X-rays. Management, maintain a safe distance and wait for the hazmat team to decontaminate the patient. So where are you guys going to stage on a hazmat incident? Uphill and upwind. You don't want to be downhill and downwind just in case something happens. So call for additional resources to remove the patient's clothes, begin ABCs and treat burns or trauma, irrigate open wounds. Notify the emergency department. Let them know what's going on. Identify the radioactive source and the length of the patient's exposure to it. Like I said, you want to notify the emergency department because they might stick you in a special room. They might want to get some things together before you guys show up. Limit your duration of exposure. Increase your distance from the source. Attempt to place shielding between yourself and the sources of gamma radiation. So all wounds require bandaging. Splints can help control bleeding and provide firm support for dressing. There are many types of dressings and bandages. So you guys have pictures of here. Multi-trauma dressing. Looks like a ice pack up here. You know, you got your 4x4s, a little bit larger ABD pads, your abdominal pads, and then your rolled gauze. So once you put a sterile dressing on or a 4x4, you could actually wrap this around the dressing to help keep it in place. Dressings and bandages have three functions: to control bleeding, to protect the wound from further damage, to prevent further contamination and infection. Sterile dressings. Most wounds will be covered by universal dressings, conventional 4x4 and 4x8 gauze pads, assorted small adhesive type dressings, and soft self-adherent roller dressings. Universal dressings are ideal for covering large open wounds. Gauze pads are appropriate for smaller wounds. Adhesive type dressings are useful for minor wounds. Occlusive dressings prevent air and liquids from entering or exiting the wound. Bandages. To keep dressings in place during transport, you could use soft roller bandages, rolls of gauze, triangular bandages, adhesive tape. The self-adherent soft roller bandages are easiest to use. Adhesive tape holds small dressings in place and helps secure larger dressings. Do not use elastic bandages to secure dressings. The bandage may become a tourniquet and cause further damage. Splints are useful in stabilizing broken extremities. Can be used with dressings to help control bleeding from soft tissue injuries. If a wound continues to bleed despite the use of direct pressure, quickly proceed to the use of a tourniquet. So review. A young male was struck in the forearm with a baseball and complains of pain to the area. Slight swelling and ecchymosis are present, but no external bleeding. Which type of injury does this describe? Remember, you have open and closed injuries. What type of injury is this? You can knock two out of here right now. So B, contusion is caused by direct blunt force trauma. Epidermis remains intact, but small blood vessels in the dermis are injured. The depth of injury varies depending on the amount of energy absorbed. Pain and swelling occurs as fluid and blood leak into the damaged area. The buildup of blood produces a characteristic blue and black discoloration called ecchymosis. So abrasion, it's going to be an open wound. Avulsion, it's going to be an open wound too. It's a penetrating injury. A hematoma is more is blood that has been collected within damaged tissue or in a body cavity associated with large blood vessel damage. So usually it's gonna produce a large swelling area. So that's gonna be a little different than a contusion. So a compression injury that is severe enough to cut off blood flow below the injury is called So D, compartment syndrome can occur when a part of the body has been compressed for a prolonged period of time, usually greater than 4 hours. The injured tissue begins to swell, which can impede arterial blood flow and venous return. As a result, a part of the body distal to the compression site becomes hypoxic and metabolic waste products, i.e. lactic acid, begin to accumulate. So a 45-year-old convenience store clerk was shot in the right anterior chest during a robbery. Your assessment reveals that the wound has blood bubbling from it every time the patient breathes. Your most immediate action should be to So A, immediate treatment for a sucking chest wound or open pneumothorax involves covering the wound in an inclusive dressing. This will prevent air from being drawn into the chest cavity. After covering the wound, assess for an exit wound, apply high flow oxygen if not already done, and transport promptly. What effects will the application of ice have on a hematoma? What's the reason you put ice on a sprained ankle or a swollen extremity? So D, applying an ice pack to a closed wound such as a hematoma will decrease bleeding, pain, and swelling by causing constriction of the blood vessels. So this is why you put an ice pack on your sprained ankle. Primary reason for applying a sterile dressing to an open injury is to, you guys should all know this by now, B, although prevention of contamination is an important reason for applying a sterile dressing to open injury, the primary reason is to control the external bleeding associated with it. The most appropriate way to dress and bandage an open abdominal wound with a loop of bowel protruding from it is to So C, treatment for an abdominal evisceration includes applying a moist, sterile dressing to the wound and covering the moist dressing with an inclusive dressing. Do not replace a protruding bowel back into the wound or apply firm pressure, which may force the bowel back into the wound. These actions increase the risk of infection. So never try and replace abdominal organs. Always cover with the sterile, moist dressing. Transport. So a 22-year-old male was attacked by a rival gang and has a large knife impaled in the center of his chest. Your assessment reveals that he's apneic and pulseless. You should. What are the only two times you're going to remove an impaled object? So A, as a rule, impaled objects should be stabilized in place. However, if they interfere with patient's breathing or your ability to perform CPR, they should be removed. You cannot perform CPR on a patient if a knife is impaled in the center of the chest. Carefully remove the knife, control any bleeding, begin CPR and transport at once. The AED is not indicated for patients with traumatic cardiac arrest. Their arrest is usually caused by massive blood loss, not a primary cardiac dysrhythmia. So this is why we don't work on traumatic full arrest, because they've lost too much blood. Which of the following is considered a severe burn? So what does it say in your book? It's considered a severe burn for you guys. So D, severe burns include the following: full thickness burns involving the hands, feet, face, airway, or genitalia. Full thickness burns covering more than 10% of the body's total surface area. Partial thickness burns covering more than 30% of the BSA. Burns involving the respiratory tract. Burns complicated by fractures, and burns on patients younger than 5 years or older than 55 years. That would otherwise be classified as moderate burns on younger adults. So make sure you know which are your moderate burns and which are your severe burns. So a 5-year-old boy was burned when he pulled a barbecue grill over on himself. He has partial and full thickness burns to his anterior chest and circumferentially on both arms. What percentage of his body surface area has been burned? So remember your rule 9s. Remember that pediatric and children burn surface areas are a little different than on adults. So he's got his whole anterior chest burn, and he has both arms burned circumferentially, so front and back. Remember. So B, using the pediatric rule of 9, the anterior chest accounts for 9% of the BSA. The entire anterior trunk, which includes the chest and abdomen, accounts for 18% of the BSA, and each arm accounts for 9% of the BSA. Therefore, the child has experienced 27% BSA burns. So which of the following statements regarding chemical burns is false? So what's the first thing you're going to do for a dry chemical burn? So C, dry chemicals should be brushed off the patient before irrigating the wound with sterile water or saline. Failure to do so may increase the burning process and cause further tissue damage.